Well, hi everyone. I am here live with none other than Dr. Andrea Salcedo, otherwise known as the Conscious Gynecologist. Hi, Dr. Salcedo. Thanks for speaking with me today.
Yeah, hi, Christy. Thank you so much for the opportunity. I really appreciate you taking the time to talk to me.
Absolutely. I'll never forget the first time I saw you on a video and I was like, "Oh my gosh, she's a doctor in the space that I hadn't heard of before." And I was so excited to get to meet you. We've spoken before on my other podcast, Lioness Lifestyle, but I wanted to, have a one-on-one chat with you today. And I'm hoping that we can start by digging into your own personal story and how did you come to be a metabolic health practitioner? I'm sure it probably had to do with your own personal health because a lot of doctors I know are not okay with, a low carb, high fat approach.
Yeah, well, thanks for that. And yes, I am a board certified OBGYN. I am full scope, so I do medication, surgery, and a lot of lifestyle, intervention. I work at Loma Linda University Health, which sometimes people laugh at because it's a little bit of a paradox because I'm very much leaning more animal-based protein and low carb dieting, and it makes people laugh because a lot of folks know about Loma Linda and being very plant-based, but mostly holistic and health, which is awesome, and I think that's where our goals align. But just like many folks in this space, I started to grow a little frustrated about my own health and how a lot of my own medical concerns and problems weren't being addressed by the standard of care. And so there's two stories I have. And the first is I actually, when I started off when I was my early career as an OBGYN, I was 1 or 2 years out of training after, 10, 12 years of really hardcore, training and residency programs. I finally was practicing at a big, HMO conglomerate in Southern California. Everybody kind of knows who that is. And I started having really heavy periods and painful periods, and which seems to be pretty normal for a lot of people, like 7 days, kind of flooding. And I had kind of had heavy periods for a while, but it started to get worse the harder I was working and the more stressful life was. I was on what I thought was a healthy diet. I was eating a lot of chicken and quinoa and lentils and, having a little bit of alcohol here and there, not anything excessive, 1 or 2, beers on the weekends, like it wasn't like crazy. But I started having a lot of really heavy periods and I was seeing patients in between, and going to the restroom and having to change my pad really, because I was flooding. And I thought, I'm a board certified OBGYN. How come I'm having problems with my period? Well, it turns out one of my colleagues ordered an ultrasound and I had a 9 centimeter endometrioma. And so an endometrioma is a blood-filled cyst that is related to the problem called endometriosis. And endometriosis is basically when the lining of the uterus escapes out of the uterus and implants into different areas of the uterus. And it's associated with really bad pelvic pain, heavy painful periods, but also infertility. And I didn't think I had endometriosis at that time because I already had a son. Um, so, I had this big blood filled cyst and I did what every compliant, patient and OBGYN would do. I went ahead and had surgery to remove the endometrioma. Well, I ended up losing my right ovary in the process, which is unfortunately one of the possible side effects that could happen. And I was a little bit sad because I wanted to have another baby, but it particularly challenging because when we remove an ovary from a childbearing woman, what we have in mind is to try to protect the remaining ovary so that that ovary doesn't get afflicted with endometriosis and then have to remove that one and then have early menopause. And so the big recommendation amongst the majority of OBGYNs and standard of care is to start a woman on some sort of hormone suppression therapy like birth control pills. And I just didn't want to do that because I wanted to have a baby. And so it was like, that doesn't really blend well with my own personal goals. And I just felt really frustrated. And for the first time, felt like what my patients probably would feel when I would recommend birth control pills or hormone therapy for a problem that didn't really have a whole lot of solutions, right? And I think birth control pills are really great for birth control. And, even for some, other problems that, minor things, like, maybe painful periods or heavy periods for women who are not interested in childbearing. I think it's a really good option. But when someone like me who was looking for fertility, future fertility, I was really sad and frustrated. And so I did a deep dive in the literature and I started reviewing all kinds of things about what endometriosis really was. And I started looking at root cause because I really felt like endometriosis, I was just treating the symptom of the heavy period, just thinning the lining of the uterus, but I wasn't getting to the root cause. And what we know is the root cause is endometriosis is a gut microbiome disorder. It's basically inflammation that leaks down into the pelvis that causes body inflammation in the pelvis. And then when women have their menstrual cycle, the blood leaks from the vagina, but it also leaks through the fallopian tubes. And if your pelvis is already inflamed from leaky gut, then you already have immune factors in your pelvis that are trying to repair this leakage of tissue and proteins and inflammatory cytokines that go down. Then when the lining of the uterus gets trapped in those areas too, it actually creates a new blood supply. And so those menstrual cells bleed just like any other cell in the lining of the uterus, but in your pelvic cavity. And that's why women with endometriosis have a lot of pelvic pain and bloating and pain with intercourse or pain when they defecate or they go number two when they're on their period because of the extra sites of endometrial or menstrual tissue in your pelvis that is bleeding just like the lining of the uterus. And so, anyway, that was kind of one of the big reasons why I got into this space of figuring out how does metabolism play a role? How does insulin resistance play a role? And how does diet play a role? Then earlier, even before all this is, I ended that was my first like major, crossroads with how metabolic health plays a role in this space in gynecology. But then when I did finally get pregnant after reducing a lot of the grains in my diet, I started going gluten free and I started feeling a lot better. I did get pregnant, and in my third child, I ended up getting gestational diabetes. And gestational diabetes for me, it was really unusual because I was 120 pounds at 24 weeks pregnant. Other than my age, and being Latina, I didn't really have a whole lot of risk factors for gestational diabetes. And so when I found out I was gestational diabetic, again, it's a problem of insulin resistance, eating too many carbs. And so because I said I was gluten free, then many of us use the alternative of not using gluten, but other grains, right? So I started using quinoa and corn and stuff. And all those things made my blood sugar go crazy high also. So then I realized that, wait a minute, maybe we really don't need all of these starches. Maybe I just need to be feeding my body and my baby healthy fats like animal fats and proteins and stuff that will help sustain the hormone metabolism that's happening during pregnancy. And my sugars were great. I ended up having a perfect, vaginal delivery. He was only 6.5 pounds, actually my smallest of my three boys. And it was a really great experience. But all of those stories really, in summation, are to share that the frustration that I had of standard of care OBGYN and telling women they have to have carbs for their babies, they have to take birth control pills to control their painful periods. And so then it just really opened up how metabolism really plays a role in the development of female gynecologic and obstetrical concerns.
Man, I wish I would have known you when I was having my kids. That was a long time ago, though. Mine are,
I know, I'm sorry, it's a
they're
long story, but
yeah, no, I wish I would have known you back then because I feel like that all my pregnancy and all that could have gone so much more smoothly. So now you're a metabolic health practitioner. In fact, I think I watched all the videos of Low Carb San Diego. I didn't go myself, but I'm pretty sure I saw you there. I'm like, I think that's Dr. Andrea in some of the videos from Low Carb San Diego this year. So what does it mean to be a metabolic health practitioner? Do you get like a certification for that? And how do your patients find you? Do they come to you because of that? Or do you kind of sneak that in? And have you changed anybody's mind?
And so how do you become a metabolic health practitioner? What does that mean? Really, it means that you're a clinician with a special interest in physiology, because really what we're teaching is nothing but like biochemistry and physiology and disease process development that we all learned in medical school and nursing school, or at mid-level provider school, any of those basic biology and physiology. We all learned this stuff. We learned about ATPs. We learned about the TCA cycle and breaking down glucose and fructose and stuff, and how that develops into disease. The problem is that when we go into finally we go into training and get a prescription pad, then we forget about how to treat disease, because we're able to prescribe people medications that will kind of mask a lot of the disease pathology. And it just kind of covers up the symptoms. So any clinician and even health coaches can look into being a metabolic health practitioner. Specifically in medicine, it's basically bread and butter medicine, but it's just going back to what we have learned instead of relying on medications to treat our patients. And so pretty much for the majority of problems out there, chronic medical problems, lifestyle is the way we treat these chronic medical problems. If I have a patient that comes to see me for polycystic ovarian syndrome, American College of OBGYN says that we're supposed to be talking about lifestyle and exercise and diet recommendations first. But what gives people so much frustration is that the recommendations for those areas were low fat diets, high starch and grains. And all of those things raise glucose levels and high insulin levels, which eventually cause the irregular periods. And so, I think it's just really lending our brains to go back to physiology. And so when patients finally, come to see me, they're kind of frustrated with, how the regular medical groups just give medications, offer surgery, and they're really looking for root cause. So I do have a telehealth gynecology practice called consciousgynecology.com, and women can in California and Florida and internationally can make appointments with me, and we can do a metabolic health consultation. And then if you want to see me in person, I am at Loma Linda University Health. I'm an OBGYN there, and anyone can come and see me there. But that's kind of what I was doing this morning. I was seeing patients in my telehealth practice, and it's really successful and a lot of fun. I spend a whole hour with patients in my telehealth practice. I show them foods and things that I do, on my website, and how, you can make an appointment. But it's a lot of fun. And usually by the time people come and see me, they're kind of sick of the standard of care, and they just want to learn a little something different. And, honestly, I think what I do is pretty standard stuff and what most of us should be doing, because it relies entirely on understanding of physiology.
Yeah, that's amazing. When I first started with a keto and then a carnivore diet, I actually ended up changing my medical provider, because all she wanted to talk about with me was my cholesterol, and it just was very frustrating. So I'm sure for patients looking for someone like you, it's kind of a breath of fresh air. So my new provider she's like totally open to it. She's done keto before herself. She doesn't have a problem with my cholesterol, so we can like address any other needs, that may arise. And so I can only imagine people come to your office and just feel so relieved to not have to kind of have this fight with their provider. I want to talk now about,
and there's lots of ways. I was just going to tell one more thing, Christy, I forgot to mention, is that you mentioned, how do you become this? And, if you have a special interest, if you're a doctor, nurse, or a health coach, Nutrition Network is a wonderful organization based in South Africa that offers certifications. I did that certification. You don't have to do any of these certifications, but they're very helpful because it's very structured and organized. The Society of Metabolic Health Practitioners also has a really great certification pathway. Or you can just be, a learner and just, look at a lot of the references from, books like from Jason Fung, and, Mindy Peltz, and all these folks that are doing really great work in this space. So you don't have to have a certification. Sometimes it's nice to go with these programs because it's very structured, but there's lots of ways that you can do this in this field.
Yeah, that's awesome. And I know there's a lot of conferences out there too. Like I mentioned, the Low Carb San Diego, things like that, that I know a lot of doctors
right.
will attend. I met several of the physicians in this space at Hack Your Health in Austin, Texas last May. So like, Dr. Baker was there and Dr. Boz was there. And so there's things like that too, that the doctors go to and present and attend. I wanted to talk with you about some of the common conditions that you treat that are maybe not always treated with finding the root cause, but maybe metabolic health actually is the root cause. I know one that I've heard about a lot is PCOS. And it's kind of like
Yeah.
a leading cause of infertility, which is a big deal for people these days.
Yes. So we talk about gateway syndromes in chronic disease and kind of like these medical problems that will eventually lead into other more serious medical problems in life. And in women, polycystic ovarian syndrome or PCOS is basically the gateway to all of these metabolic disorders that can happen for women. And so, polycystic ovarian syndrome is when a woman has high insulin levels that can sometimes lead to higher testosterone levels or clinical evidence of testosterone levels. So hair where you don't want it, chin hair, losing hair on the sides of your scalp, belly hair, acne, irregular periods, and sometimes tiny, tiny cysts on the ovaries that don't require surgery. And it's usually a variation of two of the three things that we had talked about. And so when you have high insulin levels, eventually a woman will turn into kind of like a pre-diabetic phase. And then that will eventually turn into diabetes. And when we have the inflammation that comes from high insulin levels in PCOS, it can lead to infertility. Sometimes, if this happens long enough for women, it can turn into uterine fibroids because the inflammation that is circulating in the woman's body, can cause inflammation at the lining of the blood vessels. And then the uterus is actually one big blood vessel, and that uterus will start to grow benign tumors of calcifications and muscle called uterine fibroids. And then that can be a source of heavy periods, but also infertility as well. And then for some women, it can actually turn into uterine cancer. And so high insulin levels is a really big source of body inflammation that can lead to all sorts of gynecologic disease. And then, of course, I alluded to endometriosis earlier. And so how do you reduce insulin levels and how do you reduce, glucose? Well, we know that a well-formulated low-carb, high-fat diet, a ketogenic diet, or a carnivore diet really does help bring that insulin level down because it doesn't rely on higher glucose or levels to activate insulin to increase to manage all that stuff. But remember, we're not just like this one isolated organism that is processing glucose. We're also, sometimes we struggle with sleep, or sometimes we struggle with boundaries, and we have a lot on our plate and we're working really hard. Maybe we've dealt with trauma. Maybe we've dealt with like a spouse who is not right for us. But all of those things can activate our inflammation. They can activate our adrenaline and stress hormones and catecholamines and start to elevate our insulin. And insulin is kind of like our nature's thermostat. And, if for better or for worse, like women were made to have babies, right? Whether or not we agree with that or not is another story. But biologically, we were made to have babies. And so the biologic investment to actually having a baby is huge. It's like 1 year of having, or 1 year of, carrying a baby, and then 2 years of active child rearing where we're not doing anything else but babies, right? And so it's a good 3 year investment. So your body's going to totally protect yourself from having a baby at a time that's not right. Now, whether it's high glucose, it's stress, it's smoking, it's not a healthy lifestyle, it's not, not sleeping well, all of those things raise glucose, and that raises insulin, and insulin sends a signal to your brain to actually stop ovulating so that you won't have a baby at a time that's not healthy for you. Okay. And so how many times do we know of women who struggled with infertility, and then they've gone through treatments and all this stuff, and they finally go on a vacation with their spouse and they get pregnant? Well, that's just because their body had finally felt safe enough and their insulin level went down so they can actually, conceive and feel like a normal, healthy, safe person. But insulin is like the North Star. Insulin is like the big reason why women struggle with so much inflammation. And so low carb diet, ketogenic diet, or carnivore diet, all those things really reduce insulin so that women can help lower their insulin levels and have a better metabolic gynecology lifestyle.
So, can we dig into that diet a little bit more? I'm thinking of a woman that I work with. She's amazing. She's not trying to get pregnant. She's past that stage, but she recently got diagnosed with as a pre-diabetic. She doesn't eat like I eat. She's new to my school, so I'm like gradually kind of talking to her about this kind of
Yes,
stuff. But they
yes.
put her on metformin. And she'll tell me a lot like, well, I don't eat a lot of carbs, but then I see what she eats for lunch, right? And there's like rice in there. And I think sometimes when people think of carbs, they're thinking of processed food type of sugar. So can you kind of go through what a low carb diet would look like that you would tell your patients to go for that would be metabolically beneficial for them?
Yeah, because I think so much of our counseling, it revolves around the word sugar and glucose and carbs. And I always tell patients, like, I know you're not binging on Ben and Jerry's every day. I know you're not drinking soda all day long. But there are probably some sources of hidden carbohydrates that we don't really know or realize. And so I tend to use the word starches a lot in a lot of my counseling. And so starches are beans, rice, potatoes, pasta, bread, fruit, quinoa, all those things, all those grains. And that can be sometimes really challenging for women to hear because we've heard so much narrative about plant-based and eat the rainbow and, just all of the kind of vegetarian options, which it may work for some people, but it doesn't tend to work for a lot of people who have struggles with prediabetes, right? Because those are sources of carbs. And I remember when I was gestational diabetic and I thought I was eating healthy and I was eating, I had one lunch where I brought, to work and it was chicken and quinoa. And it was about a cup of quinoa. And I thought quinoa was pure protein. Like, I thought that it was, like, not at all a starch, and so when I took my blood sugar after I had my lunch, it was 160, which is really high, and I
Mm.
was like, "Gosh," and I was talking with a dietitian about it, she was like, "No, quinoa is starch." I was like, "What?" Like, I totally didn't know. I thought it was free protein, right? And so I think it's just reframing what we believe is healthy. And I think the word healthy also imposes a little bit of shame on people, right? Because it's like, oh, it's like you're choosing to make a healthy versus an unhealthy choice, right? And like, I don't think that's what people are looking for. I think that they just want to understand what foods are nourishing and cause really great satiety, right? And so, and for me, because I'm so focused of like the insulin and the glucose and stuff, and the inflammation, a lot of those types of foods tend to bring about a lot of inflammation. And so, especially when people are like, gosh, I've been doing this for so long and I'm still pre-diabetic and I've been eating this way, like something's wrong, right? Well, sometimes you kind of have to get a little drastic and think, well, how's that working for you? Like, how's this, high grain diet working for you? And if you're really looking for something different, like I can totally teach you this other way and it's going to challenge your worldview. But if we think about the actual fat and the protein that are necessary for our body's processing, I mean, when I teach women that cholesterol is the building block for all of our hormones. And how do you get cholesterol? Well, by eating it, because 30% the daily requirement of cholesterol that your body produces is only 30% from your liver. Everything else has to come from your diet. So it's as simple as that. So when you teach women how physiology kind of comes to be and how hormones and proteins are made, it may bring a little light bulb moment to them. But then also food guides are really helpful. And the Diet Doctor website has some really great food guides that teach women that, hey, like 1/2 cup of white rice or beans or lentils or whole grain brown rice equals the same amount of sugar as a half a can of soda, or 1 cup of any of those grains equals the same amount of sugar as a can of soda. And when you frame it like that, it's like, what? And then we have a bean and cheese and rice burrito. And it's like equivalent to drinking 3 cans of soda. And so, yeah, I mean, it's just kind of reframing. And once people are ready to hear that message, then it's makes the conversation so much easier. But the food guides really do help women understand how much impact certain fruits and vegetables really have on their life.
Yeah, we definitely ate meat growing up, but I can remember my mom teaching me stuff like, well, if you like eat rice and beans together, then that can make a complete protein and all this kind of stuff. And so I don't think people think about, and she's meat-based keto now, she's doing fabulous. But anyway, I don't think people think about the carb content that's in there. Like you said with the quinoa, you just thought that was, free protein or whatever, not even realizing or thinking about the starch, and that the starch would just turn to sugar. And I think that's, like you said, it's
That's
such a mind
right.
shift,
That's right.
especially those of us that grew up with that food pyramid, because what was at the bottom? Like grains, and a lot of them, right? We were taught that that should be the
Grains.
foundation of what we're eating, which, yes, it is a
That's
huge mind
right.
shift.
Well, the other hidden
Um,
one is the other hidden thing is fructose, which is really interesting, right? Because remember, insulin doesn't cover fructose. Insulin doesn't store fructose. And so the only way that we can process fructose, which is from, high fructose corn syrup or fruit, is from the liver. So the liver it processes the actual molecule fructose, and through like all of these elaborate pathways, and the buildup of that is actually fatty liver, which is very interesting. And so fructose isn't brought into the cells by insulin. Fructose and glucose are two totally different molecules, and glucose is brought into the cell by insulin, but not fructose. And so we have to even be more careful with fruit. And when, a lot of times I teach patients, like, they're like, oh yeah, my glucose didn't change with fructose. I'm like, well, yeah, because it's an entirely different molecule. And that fructose causes more liver inflammation. We have to be really careful with that. And that is what causes triglyceride elevations too. And so it's even teaching women about fructose and glucose is like a mindset change.
yeah, I'll have to bring that up with my friend that I was talking to about. So yeah, because fructose it's not reflected in your A1C, correct? So you don't see it. It's like
No,
invisible when
it's
you're
not.
testing for A1C. Yeah. And
Yeah,
so,
yeah, yeah.
it's hard to, you can't really measure it very well. Right.
No. Mhm. Yeah, it's
Okay.
measured
Well,
best by triglycerides. Mhm.
okay. Yeah, my triglycerides went way down. Actually, I'm a lean mass hyperresponder. So my triglycerides very low, my HDL very high, but my LDL like really nice and up there. Um yeah, who knew? I wanted to talk to you a little bit about a couple other things. You talked about fibroids. Is that, I know like people when I was in college, there were girls with fibroids. Like, how serious of a condition is that? And is it like becoming more common in younger people?
Yes. So this is a good topic because uterine fibroids were commonly regarded as just benign growths on the uterus that aren't cancerous, rarely can ever turn into cancerous, can sometimes cause heavy periods or painful periods or impact fertility. But it was something that we would see mostly in women in their late 30s, 40s, or even 50s. And what happens is that when you go through menopause, the fibroids will start to reduce in size because they rely on estrogen and progesterone as one of the three components that help them grow. Okay. And so when you go through menopause, most of the time they'll kind of shrink out. But when women of childbearing age are kind of going through their life, if we're exposed to chronic excessive carbohydrate consumption, that causes elevation and inflammation factors that cause hardening of the arteries of the body. Well, the uterus is made of the same smooth muscle as the arteries of our, circulatory system. It's actually the same. And so we've known this since the 1960s that the same muscle fibers that cause uterine fibroids are the same ones that cause atherosclerotic disease or hardening of the arteries. But in gynecology, we don't regard uterine fibroids as cardiovascular disease risk or an evidence of cardiovascular disease risk. And so when I talk to patients about uterine fibroids and why it happened, most of the time they feel that they've heard the narrative that they've heard is, oh, it's genetic. And that's only partially true. In fact, when we look at the risk factors for uterine fibroids, it's cardiovascular disease, hypertension, diabetes, and obesity are way up here. And genes are way down here. And so, yes, it's true that families behave similarly. You know, families tend to have the similar metabolic profiles, but there's not like the fibroid gene that just because my sister had fibroid, that I'm going to have fibroids because of this gene. It's actually not true. There's a collection of what we call genetic polymorphisms, which are constellations of genes in our DNA that make us more predisposed, but it doesn't actually turn on a fibroid. And so, you know, it's the environmental factors like stress and processed food and chronic carbohydrate consumption that cause inflammation. Also, smoking will do it too. Cannabis, smoking, vaping, all those things that cause and introduce inflammatory molecules in our circulatory system and allow these collections of calcium and muscle fibers to grow. And that's a uterine fibroid. Okay. And so oftentimes when I have patients that come and see me early on, maybe they're finding out that they have fibroids for the first time and they're smaller, or and we talk about how a low carb, high fat diet can help reduce the risk factors, then it really gives them a lot of empowerment to try to figure out how they can manage this chronic condition. And so, you know, there's no data that says if you started a ketogenic diet, it's going to make your fibroid disappear. There's like no data for that. Okay. It's like data free zone. But if we're looking at the uterus as an end organ, an organ that's the recipient of cardiovascular disease inflammation, just like the heart, just like the liver, just like the lungs, then by reducing those exposures, we could potentially reduce the risk that are associated with uterine fibroids.
Wow, I just learned so much. So when you have something like uterine fibroids, so you're saying it's similar to, you said atherosclerotic disease, like what's going to cause a potential heart attack later on?
Yes. So
Okay.
it's not similar. It is. So it is. So
Same.
uterine fibroids are
Wow.
basically atherosclerotic disease of the uterus because the uterus
Okay.
is made of the exact same muscle fibers as the blood vessels that are circulating all around our body. The uterus is just one big blood vessel.
So it kind of sounds like if you have those, it's like a big, like flashing warning light on your car dashboard to say, danger, watch out, you need to change something.
Yes. Yes.
Wow.
And the thing is that as gynecologists have gotten so good at treating uterine fibroids with medications and surgery, because a lot of times, and here's the thing, it's like women who have uterine fibroids tend to have heavy periods as, with it, right? Because it'll stretch the lining of the uterus and make more area for the uterus to bleed. And sometimes they're like heavily bleeding where they need like blood transfusions, or they can't go to work, or they're like changing their pad all the time and having flooding accidents, and like they're missing out on like important events in their family because of their menstrual cycle. It's definitely no way to live. And so we are taught this very incredible and life-saving skill set to treat with medications or surgery. Okay. But we're so good at that, we have forgotten to teach women how they got there. Okay. And so I have plenty of women who come and see me and they're like, yeah, I have uterine fibroids. Like, what are my options? And it's just depending on how bad they are on the spectrum, how severe the disease is. We talk about lifestyle, medications, or surgery. Okay. And some women, I jump right to surgery because they've been in the hospital twice with blood transfusions and stuff. And it's like, okay, like if I tell you to do a ketogenic diet, that's good, but that's not going to make this problem get a whole lot better right now. And so, but I can remove your uterus and tell you that, hey, your uterus is a manifestation of all this chronic inflammation that you've been going through. And yes, we can do a life-saving hysterectomy, but you still have blood vessels all the rest of your body. And so you still have to protect your health. And so by teaching them that their uterus is just a source of inflammation that the other organs are receiving as well, then they can reduce their risk of cardiovascular disease events later, like heart attacks and strokes. And we know that women who have these gynecologic problems are way higher risk than the other rest of the population at developing those problems.
Hmm. Wow. Well, I hope they're listening to you when you say that after the surgery, they go keto or carnivore.
That's right. That's
Okay.
right.
So we've talked a lot about like specific to gynecological conditions. That's a lot of syllables. I Can we jump into like the pregnancy stuff? And because
Yeah.
I can remember being pregnant and going to my OBGYN, and like I it was either the food pyramid or the my plate. There was one of those on the wall in there, and
Yeah.
being told very little about diet actually coming out of their mouth. But definitely like lay off the fish. I think I was told, I don't know, it's been a long time. And you know, I had a lot of problems with like passing out early on, and need, like I'm a teacher, and so it would always happen in the morning, and I would be like, I got to put my head down, and I would, my teaching partners would take over PE, and by the time that was over, I could kind of like get it together, you know, to like do the rest of the day. But it felt like a lot of not just regular morning sickness, but I was never told, and I don't know, because I was never told like, does diet, you know, play a role in that? What should people that are pregnant be eating, in your opinion? Um, and then maybe if we can get into some of the complications that could happen, like you were talking about your own gestational diabetes.
Yeah. So thank you. This is another exciting subject for me. And man, I feel like we don't talk about this enough, even in the first trimester. And we almost like create like pathology, like I think it's like pathologize like the first trimester of like, oh, nausea and vomiting. And let me take you through like, what is the biologic adaptation for nausea, vomiting, and nausea in pregnancy in the first trimester? And we'll talk about how that relates to later in the pregnancy. So, um, most women in the first trimester don't really want to eat anything. Okay. Like they have this like aversion to different foods and stuff and smells and things. And a lot of times they have aversions to cooked meat, you know, or anything roasted. Okay. And now, why is that? Well, because if we think about it, we haven't had refrigeration until the last maybe 60, 70 years where everybody's had like a refrigerator. Okay. So before then, meat was a huge source of food poisoning. Okay. And so your body's going to want to try to protect you from getting food poisoning or like a parasitic disease in the first trimester from uncooked meat or from meat that's not you know, been processed well. And so in that first trimester, that's where the aversion comes from. But the other part is that if the when we would cook meat when we were like cavemen, right? It was like over an open flame, right? And so what happens when you cook meat over an open flame? Well, the meat gets like this char on it, right? And when do you not want to introduce charred items into your body? Because charred items are carcinogenic, right? And carcinogenic means that they can cause a higher chance of cancer cells in your body from the inflammation and from like the burned areas from all of those carcinogenic substances on burned things. Okay. And so that's why people who eat like smoked things or you know, highly barbecued things are have a higher chance of cancer in their life. Well, when do you not want to introduce that? Well, when the first trimester, when the fetus is like rapidly growing and there's like all kinds of new DNA that's forming, and you don't want to cause intercalating problems of like DNA development during that time. And so, for those two reasons, is why women tend to have these aversions to like coffee, which is roasted, right? And meat in that first trimester. And so the other piece to that is that your blood volume is going to start to increase by about a third in that first trimester. And so when that happens, you tend to get a little bit depleted in your electrolytes, and people start to get a little bit dizzy, and they start to get pretty dehydrated. They're gasping, like they're air hungry. They're like taking these deep breaths for air. And that all has to do with like the increase in blood volume that actually starts to dilute some of our red blood cells that are circulating around. And so salted lemon water is like a wonderful way that women can help improve that like sense of thirst and that dehydration feeling. And it's not just water, it's like a little bit of magnesium and some salt or those electrolyte powders that a lot of people are doing. But the last piece of this is how we regulate blood sugar. Okay. So in the first trimester, the baby doesn't have a pancreas yet. Okay. And so it relies entirely on mom's normal blood sugar to keep the blood sugar steady and low, because high blood sugar will tend to cause brain inflammation to the developing fetus in the first trimester. Okay. The baby has no way to regulate it. And so it doesn't have, because it doesn't have a pancreas, it doesn't have insulin. Okay. And so because of that, it really relies on mom's aversion to food to keep blood sugars low and ketones high for the baby. The baby actually needs ketones for brain development in that first trimester. Okay. And they're actually produced by the placental cells to help with baby's brain development. Okay. And so a lot of women feel really bad in that first trimester because they're not eating, and they're not eating for two and stuff. Well, it's okay. If you're not hungry, don't eat. All right. Just make sure you stay hydrated. And that would really help women get through that first trimester. Eventually, you'll want to eat something. And so, yeah, I mean, women will have like a little bit of crackers or some cheese, or just light things all day. And that's okay. I don't really want women to feel bad about eating carbohydrates in the first trimester or not eating meat or whatever. Just eat what you can, just so that you can get through it. But we just don't want women like, binging on ice cream or frappuccinos or processed food, especially in that first trimester, because we don't want blood sugars to go all crazy and develop and cause inflammation for the developing embryo in the neurologic system. Now, as the woman progresses into her second, once you get to around 24 weeks, there's a hormone that is produced from the placenta called human placental lactogen. And that hormone causes a little bit of physiologic normal insulin resistance, which means that it increases a little bit more glucose in the circulation of the mom to feed to the baby to help with its own regulatory and metabolic mechanisms. And then eventually we want a little bit of a higher glucose. So when a woman breastfeeds after the baby's born, some of that glucose gets, shuttled to the baby. And so it helps with breastfeeding. Okay. And so the problem is that modern diet and culture has way more glucose and fructose exposures in our environment than what our ancestors used to have. And so because of that high levels of glucose can cause the baby to grow way too big for your birth canal, or moms to gain too much weight so that the babies don't fit through the birth canal, or that inflammation of glucose and high insulin in that first trimester can actually impair how the placenta is implanting onto the lining of the uterus, and then increase the risk for preeclampsia or high blood pressure in pregnancy or growth restriction problems in the fetus later. And so really trying to avoid processed foods, not eating too much starches, and just kind of only eating when you're hungry makes the most sense. Just trying to be, eat meat when you feel like it, because some people have aversions and stuff, but not to have these giant spikes and overdo it with the carbs. And milk too, because milk is a huge source of carbohydrates. Just to keep things steady is very, very helpful. And you're right, Christy. I mean, gestational diabetes can develop because we overconsume on carbohydrates. And in fact, like 20 years ago, the standard of care was to not screen everyone for gestational diabetes. It's actually still the standard of care to not screen, or the recommendation. The actual screening recommendation is to screen people who have risk factors, which is obesity, Latina race, family history.
They screened me.
Diabetes. Yes, everyone gets screened because most people have that risk. Okay. Somewhere in their, medical history, but you don't have to screen everyone. But if you have the risk factor, then you should get screened. The problem is that everybody has the risk factor now. And so, but 20 years ago, many people weren't being screened because they didn't have the risk factors. And so, a slender Caucasian woman with no family history of diabetes wouldn't need to be screened. But someone like me who is Latina would need to be screened because of my ancestry, and because we have a higher risk of diabetes. And so even if you've had a macroscopic baby, or a baby that was bigger than 4,000 grams, you are automatically categorized as having a higher risk. And so you should be screened. And so, but, 20 years ago, that was not the case. The risk factors for gestational diabetes are much lower than they are right now, which is very interesting. So that's why everybody gets screened.
Mm-hmm. There's a viewer that's asked a question. I promise, Josephine, I will get your question, but I have a follow-up question on the gestational diabetes. So if you have gestational diabetes, does that increase your risk factor for like type 2 diabetes even after the pregnancy is over? Because I know a person that I work with who had gestational diabetes, and now she's been like a year and a half or 2 years or something since she had that baby. And it's just like her diabetes has just gotten worse to now she's like on insulin, I think 4 times a day. I feel really bad for her. I talk to her about keto all the time.
Yeah, it sure does. So the lifetime risk, if someone were to have gestational diabetes, even diet controlled, is 30 to 40% lifetime risk within 10 years of developing diabetes in 10 years, which is pretty crazy. If you're of Latin American ancestry like me, that risk is 50% in 10 years. And so that's why I really adhere to this lifestyle, because there's no way I'm getting diabetes. And, I'm what we call the diobesogenic habit test. So that means that like I'm the slender person that will tend to fool doctors into thinking, oh, she doesn't have diabetes, she's so thin. Well, I did my glucose tolerance test. I was 122 pounds, 24 weeks pregnant, and my glucose tolerance test was 200, my 1 hour glucose. And everybody was like super shocked and surprised. And I wasn't binging on hot Cheetos or Starbucks every day. I was having quinoa and chicken, and so we just have to be really careful about what our risk factors are and understand that. But yeah, the lifetime risk is high. So, if you've had gestational diabetes, even if you were diagnosed, and were diet controlled, you still have a higher risk. You have to be really careful.
Thank you. I was just genuinely curious about that. Josephine would like to know, have you ever heard of a woman that bleeds after being with their man every time? She's been to a few doctors. They all say she's fine, but I've never heard anyone talk about it. Could it be the food?
So, if we're talking about bleeding after sex, so we call it postcoital bleeding, or bleeding after intimate contact, intercourse, penetrative intercourse, orgasm. It's really important to be evaluated by a gynecologist, because we need to make sure that we're not missing an abnormal pap smear or abnormal cervical cells. And so that's like the major thing, is that we really need to make sure that we're not missing an abnormal pap smear, because that could definitely be a sign of cervical cancer. The other thing that it could also be related to is a sexually transmitted infection. And so sometimes there is like an infections that cause irritation on the cervix that can be related to what we call cervicitis, or the cervix can bleed with penetration of sex. And so that's important. And so once all those things have been ruled out, then we can say, oh, it's probably just some blood vessels that are a little bit irritated. Or even just an overgrowth of normal bacteria can do this, called bacterial vaginosis, which is not a sexually transmitted infection, or yeast infections can do that. But we got to make sure we're not missing cervical cancer or precancer of the cervix, or any kind of infections, before we go on to say that anything is normal. And so that would be really definitely my first recommendations for someone who's experiencing bleeding with sex. Now, there's certain times that women have bleeding with sex because it's positional. And so certain positions that are when women are like in a 90-degree angle with their hips. So like, these are weird words, but I'm a gynecologist and I'm kind of used to talking about describing positions with sex, but like doggy style position, or like women sitting right on top. When you think about that, the penis will hit directly onto the cervix, and that can cause a trauma to the cervix and cause bleeding. And so a lot of times we tell people just, change your positions up a little bit so that the penis doesn't hit the cervix directly. But we really want to make sure we're not missing anything more serious when ladies are having bleeding with sex.
Okay, thank you. I have one more topic, and it's because I went to your channel, I don't know, a few months ago, and you were talking about your own kids and feeding them, a low carb way. And so I wanted to, I don't know, talk to you a lot about like, why did you do that? Have you always done that with them? Did you have to transition them into that later? I know I transitioned my 15-year-old, he is now 16, to a carnivore diet about a year ago. And it was like less traumatizing than I thought it was going to be. But I was like crossing my fingers when I brought it up to him, because, I think it's different when your kids are littler, you have more control. When they're teenagers, you have a lot less control. So I knew in my instance, it was going to take, buy-in. But I heard you relating a story about sending like some leftovers to school, and it was like purple chicken, and they, and we had to have a chat with them about, because they were teased about their purple chicken and stuff like that. So I want to talk a little bit about that, because as a teacher, I teach elementary school, I teach 5th grade, and I see what those kids eat every day. And it's a tragedy, both in what they feed them through the school system itself and what they bring from home. Like, it's not good. There's one student that I can think of that I will often see with some kind of cut up fruit or cut up vegetables. Every other kid is like chips, Gatorade, candy, and even first thing in the morning. Like if I have before school duty, they're not even supposed to eat, but they're all sneaking out their candy and chips. And I'm like, put it away, put it away, put it away. But that's it, So I wanted to talk to you about that, because, kudos to you for feeding your kids properly. But I know that it could cause some potential there for, some friction with the peers and things like that.
Yeah, thank you for that, Christy. And gosh, I'll tell you guys the purple chicken story. So I have 3 boys, and I have a 7-year-old, a 9-year-old, and a 13-year-old. And my 7 and 9-year-old, I raise them from the very beginning, like even in utero, a very low carb diet. Okay. And so since then, my kids only eat 4 times a day. They have breakfast, lunch, a 4 o'clock snack, and dinner, and that's it. Okay. And so that's how they even drank their breast milk. That's how, I fed them their bottles like 4 times a day. That's it. And so that being said, I feel like a lot of the anxiety that comes with kids with like, I want a snack, comes from the fact that there might not be a lot of scheduled regularity to meal times and stuff. And so when my kids are hungry and they want a snack, and I'm like, it's 2:30, like you just had your meal, you're going to make it if you don't eat clock, like you're gonna be fine, have a glass of water. And so like my kids hate it, but I'm always like, you're gonna make it, you'll be fine, you'll just fine, and so that being said, I'm a realist. Like unfortunately I can't control what happens at school. Like I've talked to my kids teachers about no high fructose corn syrup, no soda. I've heard of folks like tell white lies to their teachers and say that like they're gluten intolerant or whatever and stuff. And really, I don't want my kids to feel like completely left out in terms of like celebrations and stuff, right? So like there's always like something to celebrate at school, so there's always like all these holidays and things, so I just teach them like, hey, you can kind of have whatever it is that they're offering, with some, exceptions of like, I don't really allow soda, because soda really just messes my kids up. Like the high fructose corn syrup definitely causes like a lot of the ADHD, like inattention that we see. And so like, I just say no to that. But outside of that, I'll just tell them, hey, you know what's good and what's not. And so, and I basically rely on the teaching that I've done at home. And so when we eat at home, let's say, for example, dinner, we have 3-course meals. Okay. And so the first is always like some sort of veg with like a fatty sauce on it, so it's like green beans with like a lemon cream sauce. It's like super easy to make. And I give it to them up at first course, because vegetables are like what I'm trying to teach my kids to eat sometimes, and so like we're not like a high veg person, but I do want them to be able to eat most foods. And so when they're the most hungry is when they're the most amenable to eating like a vegetable. But I always make sure that it's like drenched in oil. Okay. And so that's the first thing. And then the second course is like some sort of meat protein that I know they're going to love. So like salmon or chicken with the skin or steak or something like that. So it's like veg and then a meat protein. And then always dessert. Okay. And so in my family, dessert looks like maybe some full fat cream based ice cream that I know if I give them a less than half a cup, it's going to be less than 20 grams or so. And so we have that, or a half a cup of sliced fruit with lemon and salt, or maybe a cookie that we made. But like it has like, I know exactly what's in it, and I know that the carb content's going to be less than 20-ish grams, which is kind of like what I try to keep my kids at through, every meal. Because here's the thing, like I'm a keto doctor, like I love metabolic health and all this stuff, but I'm not crazy. Like I feel like I have to be able to teach my kids how to eat well. And so that when they don't eat well, they're like, oh, like forget, I'll never eat that again, and that's kind of like what's happening with my 13-year-old. He's getting to the age where he's starting to go through puberty, and there's acne and all that. And so I always tell him like, okay, when you get a pimple or something, like it's usually from what you've eaten from about 2 days before. And so it's usually like he had chips, or a pizza or something with like vegetable oil or like some high fructose corn syrup, some processed food. And within 2 days, he's going to get a pimple, and he knows it. Or like with, he'll start to get really sleepy, and the sluggishness that people feel with certain carbohydrates. And so anyway, to bring this back to like the purple chicken story is, my middle child, we always make enough food for dinner so that the kids can take it home to school in thermoses as leftovers the next day. Well, one day I made like a roasted chicken and like a roasted chicken, like Waldorf salad. And so I had chicken with like walnuts in it and little tiny apple pieces and frozen cherries. Okay. And so with mayo, and we like, mixed it all up and had a few crackers, and it was delicious. Well, the next day, the cherries turned the chicken purple or pink, really bright, because they had been in the fridge all night and stuff. And some of the cherry was kind of leaking into the rest of like the sauce. And so I didn't even think about it. I just put it in their little thermos with ice, and I sent it with a few crackers, and my son opened it up and was all excited, and his little girl next to him was like, ew, purple chicken, that's gross, and they totally made him feel terrible about it. And he didn't eat, and he came home all sad and was a little bit tearful, and was like, why do we have to eat like this? Why can't you just send me with the peanut butter and jelly or like whatever? And I felt really bad. And so I had to have a conversation with the teacher and just be like, like, can we have a reminder with the students, like, to not comment on other kids' food, and just a reminder to just say like everyone comes from different backgrounds, and we don't want to make anyone feel bad about what meals that they're being prepared. And so yeah, but my kids eat great. I mean, will we follow that rule of, try to eat like, natural based foods and low carb and stuff? They do well. I mean, this weekend we were in Santa Barbara, and my kids were having oysters, and it was amazing. And I'm just so proud of that, because, aren't going to make them feel well. And they're 99% of the time it's the carbs and like processed foods. So yeah.
Yeah, that's really cool that you, especially with your two younger ones, that they've just kind of grown up that way, because my son definitely didn't. I didn't even hear, like my sister-in-law at least was told, wean your kids on eggs. Like I wish my pediatrician had told me to wean my kids on eggs. No, I got the whole wean your kids on rice cereal, right? So that's exactly what I did. And
yeah.
because of a lot of other issues, which we don't have time to get into, but texture issues, and things like that. It was a lot of just processed things. And we did the goldfish crackers and all of that stuff. And he had such a severe case of ADHD with all kinds of other, not just fidgety, not just can't pay attention. We're talking full blown, meltdowns and emotional dysregulation and inability to complete multi-step directions and all of this stuff. And we tried dealing with it in all the traditional ways, and until we changed his diet. And I say we because he was 15, so he can for sure get whatever food he wants. The school food is even free. So even if he wanted to, he could go get a free breakfast and a free lunch every day.
Yep.
And he used to go do that because he liked the chocolate chip muffins and all this kind of stuff that they were, serving. Yes. And it was like, I just brought it up to him last February 1st was his first day. And it was like, he just decided he was going to do it, and he has not looked back. And I mean, awesome. It's been such a shift in his behavior. his
Yes.
attitude, which is huge when you're 16, right? His ability
Oh, yeah.
to, focus and complete tasks, organize tasks. Like, I cannot believe the difference. And so every chance I
Oh,
get when I
yeah.
meet with parents at school, as much as I can, and with my students as much as I can, I at least try to
That's
talk about,
right.
hey, more protein, less chips, please. Can we have some eggs
Yep.
for
Yep.
breakfast and don't eat the stuff that they're serving in the cafeteria if we can avoid it or if we can afford it? Where I
That's
teach, that's
right.
the issue is the families can't often afford, especially meat and protein things. But man, if they can afford it, I talk to them all I can, because yes, I see the lunchbox full of the processed foods. It's like 6 or 7 things, and every single one of them comes in a bag
Yep.
with a little barcode on there, and that's what they're eating
I
every
know.
single day. But I was never that person that thought, oh, it's the food or it's the dye or whatever.
Right.
I always,
Right.
parents would say that before I had kids. Now I would like internally roll my eyes, and think, yeah,
Yes.
whatever,
Yes.
just, but oh my gosh, it's so, so true. And I've seen the change in my own household. It's
My
amazing.
eldest was very similar. We actually kind of raised him more. The first 6, 7 years, like he was just kind of drinking apple juice and goldfish crackers and stuff. So it
Mhm.
definitely came. We had a lot of more work to do with him to get him off the sugar, and we still struggle with that with him, because we can't really control like what their friends are giving them at school and that kind of stuff. And so we have really good honest conversations, and he knows that he feels much better when he avoids the carbohydrates and stuff. But he's 13, like we're still trying to help, and help him understand, and that executive functioning is definitely not what a 14 or 15-year-old is, but we're on our way. And and I don't want parents to feel bad. It's just like teaching people, the cause and effects and stuff, and then they can figure out how it works in their family. So, yeah, good job, Christy.
Yeah. Thank you. All right, Dr. Salcedo, I wanted to thank you so much for coming on and chatting with me today. I appreciate all of your wisdom and your knowledge. And I know I learned a lot today. I hope you guys all out there watching did too. First, I wanted to ask you, do you have any upcoming projects or videos or things like that we should be on the lookout for?
Yeah, so I'm spearheading a Women's Health Day at Low Carb USA Boca. And so that's going to be at the end of January. So I'll be speaking on endometriosis, and with Dr. Jody Nishida, who is a pharmacist, and several other experts in the field. So check out the Society of Metabolic Health, the Low Carb USA events in Boca in Florida this year. We'll be doing a 3-day conference. And so I helped develop that first Women's Health Day. And you can there's a virtual option if you're interested. And so that's what's going on in the immediate next 4 weeks. But I've got lots of clinical research happening too, and of course my YouTube channel. So, and if you're interested in making a consultation, for sure, come and see me at consciousgynecology.com. But thank you so much, Christy, for all this time, and for making this a priority in your vision.
Thank you again. And we'll see you guys later. Come see us on Linus Lifestyle tomorrow night, the 7th at 5 p.m. Pacific time. I hope to roar with you over there. Bye, everybody.
Bye.